Good evening. I want to welcome everybody to this week's session of Dermatopathology or Sagis Dermpath Happy Hour. We're very pleased today to have my associate, Dr. Alanna Bree, hosting the session. Dr. Bree is a pediatric dermatologist, did her residency and fellowship in St. Louis. That's correct, isn't it, Alanna?
I did my fellowship up at Northwestern in Chicago, but residency, yes, and
Okay.
Midwest gal.
Good. She's got quite a distinguished pedigree, has practiced both in the academic and private practice settings, is the author of a a pediatric dermatology book, and has published extensively. And she's the founder and president of Made a Masterpiece Foundation, which I'll let her fill you in on, and is currently serving as director of the Sagis Pediatric Dermatology collaboration. Today, she's going to be discussing with us tips for pediatric skin biopsies. And please stay tuned to the end because we've got an exciting announcement for you. So with that, I'll go ahead and turn it over to you, Dr. Bree.
Hey, perfect. Thank you so much for that introduction, Dr. Davis, and thank you for building out this platform. It's really amazing. I wish I would have had something similar to it when I was in training. So just want to make sure everybody can see the screen that I'm sharing. Can everyone see? Thumbs up, Dr. Davis.
Looks good.
Okay, perfect. Well, then we will get going here. So yeah, I am all things pediatric dermatology, if you will. And I really want kids to love the skin they're in and to know that they were made a masterpiece. So I'm just so thankful for this opportunity at Sagis to be the director of pediatric dermatology collaboration, and so excited to be involved in the education program and to be able to mentor and teach alongside Dr. Davis here. So I'm just really excited about that role. And then I really, truly, my passion is the nonprofit work that we do through Made a Masterpiece. And like Dr. Davis said, I'll share a little bit about that. So basically, we are an organization, nonprofit organization. And what I really wanted to do is bring kids together who had skin conditions so they didn't feel so all alone. As a pediatric dermatologist, I would hear from patients that nobody understood what they were going through. And, you know, the bullying, the rude comments to their face and behind their back, which happens at all ages when you live with your condition. Basically, you're wearing your disease for the whole world to see. And so I wanted to bring those kids together because in a practice, you can't unite those kids together because of HIPAA. But the nonprofit gave me a vehicle to do that and to support the social, emotional, and spiritual aspects of living with a visible difference. And I am excited to share that Sagis is our official sponsor because they also want to partner and help kids love the skin they're in as well. So let's jump in here. So tips for less tears and fears. And this is not just for the patients, but also the people that are performing the biopsies, because as you guys might know, there can be tears and fears on both sides of performing a pediatric skin biopsy. Hopefully after this, there will be less of that for everyone. So do you really need to do a skin biopsy? I think this is a great question to start with. What is the purpose of doing the biopsy? I think in an adult practice, it can become very easy just to go ahead and get a little pinch of skin because it can add more information. But in a child, you really have to think about, why do I want to put this kiddo through a procedure that might be traumatic for both them and me? So what am I really going to do with this information? Is a biopsy going to have the potential to aid in making a definitive diagnosis that will then also alter your management? So again, I know that you guys have heard this before, but garbage in, garbage out. So basically, if you have a rash that is faint, a skin lesion that is faint, it's likely not going to pay big dividends to get a biopsy of that and look at it underneath the microscope. And if you really don't have if you think it looks like a spongiotic derm underneath the microscope, like more than likely. And again, sometimes you can get those clues. And I know that the dermatopathologists at Sagis are really helpful in helping you get that information. If you fill out your requisition form well, if you provide them with some good clinical history, I know they always love photos. That's very helpful as well. And then you increase your yield of getting information out. So if you are going to do a biopsy, take the time to fill out your rec form well, look for a place that is representative of the condition and looks kind of the most pathologic. So that will help you. And then, is the lesion eruption possibly dangerous? What is the worst case scenario? So that's what I always kind of think of, like, what is the worst case scenario if I don't get to a diagnosis today or in a timely manner? And I look at the clinical presentation. Luckily, most kids are not going to have malignancy. Now, we don't want to forget that they can develop those, because again, sometimes there's a delay in diagnosis, but we do know that in a kiddo that's otherwise healthy, the risk of something bad is fairly low. So think about your clinical presentation and then do a full exam of the patient. I really think that we do a disservice to our patients without, by just going ahead and biopsying something without doing a full and complete exam of the skin. So the cutaneous exam is one that is there for the taking. And I really do think that we should examine our patients head to toe and look for clinical signs that will help us with the diagnosis. And sometimes just doing a full skin exam makes you feel comfortable enough with your clinical diagnosis that you don't necessarily need to obtain a biopsy. And again, this is just a reminder, sick kids will typically act sick. So again, if you have a kiddo that's acting normally and the lesion or the eruption doesn't seem to be causing them any problem, it's probably not going to be something that you need to make a diagnosis of rapidly. But if they're sick, that changes the scenario. And then, as your diagnostic, could you do a diagnostic treatment trial as a reasonable approach? So a lot of times as a pediatric dermatologist, we like to kind of list out our differential diagnosis. And I know that as a resident, this is important to do, not just in training, but it's also very important to do throughout your career. I always try to come up with a good differential diagnosis and not pigeonhole myself into one diagnosis right away. And then whatever you think your leading diagnosis is, then choose an available therapy that you think would be effective for that. And don't limit the effectiveness by not going strong enough because it's a child. So if you think that a child needs a topical steroid, I would do a short course of a more potent topical steroid so that you know that did it improve or did it not? And then see that patient back and follow up. And if things are not improving, if they're worsening, the family should call you and then bring them in and consider doing that biopsy. So if you've decided that a pediatric biopsy is necessary, what can you do to make it better for yourself and the patient? So really, it's mostly common sense, just like most things in life. And just simply trying to remember what you were like as a child and what you would have liked, how you would have liked to be treated as a child. So this is a great opportunity to channel your inner child. And what I mean by this is basically you're playing a game. And if you can make anything a game with a child, it's a lot more fun for you and for them. And the whole way you win this game is if you don't traumatize the child and if you don't traumatize yourself. But you do need a basic understanding of developmental pediatrics. You need to consider the needs and the age of each child. And remember, children are not miniature adults. They cannot process information the same way. They don't have the experiences and developmental know-how to be able to process things. So again, don't treat them as if they're adults because they're not. And then really the best way is to avoid or address any stressors as much as possible with your approach and explanations. And we're going to review some of these stressors here based on age. So infants birth to one, their stressor is being separated from their family and having a fear of abandonment. So basically, to address this so that they don't sense those stressors is make sure that the family is close and present for the biopsy. and have them as close to the baby as possible. Have them, up at the head of the bed when you swaddle, if you can swaddle the patient, that will make them feel better. And I will tell you one pro tip for this, before we even get into the tips, is they have these little containers called sweeties. Basically, it's sucrose water or glucose. And you can do that with like Caro syrup and water. And if you do that and have mom put that on her finger and let the baby suck on that during the procedure, it really does help. All right, so moving into the toddler years, the 1 to 3. Here, again, the stressors are separation from family and their normal environment, fear of being abandoned again, so very similar to an infant, but they really have trouble understanding time, and a situation may seem permanent. So again, keeping parents close by, up by their head, so they can talk to them throughout the procedure is always helpful. And then just let them know that they're going to be able to just sit on the table next to mom and let them know that, what we're going to do should take no longer than it took them to eat their breakfast. And then you can kind of start talking about, so what did you have for breakfast? What's in that tummy of yours? Do you have some bananas or some cereal? And kind of be talking as you place them up on the table, so that it seems less threatening. And again, just kind of make it part of the flow, and just let them know, again, with that difficulty understanding time, that it's just going to take as long as they ate breakfast this morning, to get that done. And again, then kind of start using your distraction techniques. So heading into the preschool years, this is about 4 to 5. These kiddos may feel like their illness or their medical treatment is a punishment for something they did wrong, and they may not, and most of the times will not, understand the reason for the procedure. And then they fear this loss of autonomy. They're starting to develop their sense of self. And that's when kids notice differences among themselves and others and start to point those out. So, in this scenario, you could just let them know that, talk to them and say, I know that you have this itchy, scratchy skin, and we really want to help you figure out what's making it so itchy, scratchy. And so we're just going to have to sit up on the table for a little bit, and you get to pick what side of the table you want mom to sit on. And you get to pick what you want to listen to on the phone while we do this. So that's just a way to kind of address those stressors from the start. And then school age 6 to 12, this is quite a range. And again, the developmental milestones can happen more quickly for some kids, and some can be quite delayed, and you'll just have to kind of read the room with that. But they really have an anxiety about their illness or disorder and how it's going to affect them, and also that they might lose function of their body and they can feel helpless. They don't like, and I think none of us like, loss of control, loss of respect, loss of love, or loss of modesty. So making sure you address that, and then, they can be angry about this procedure because they feel out of control, and that can lead them to refuse. So setting clear boundaries and let them know that you want to give them control as much as possible, and that you're only doing this to help them, and they don't need to worry that this is going to help you get to the bottom of it, so that you can make things better and they can get back to being the kid that they want to be. And then adolescents and teens. And again, this can be quite variable as far as development. And again, I'd say as far as teens, especially, females do tend to develop a little bit faster, and that's just a developmental fact. So again, the girls are going to maybe act a little older than the boys at this age. So they really worry about how their illness is going to affect their appearance. And the other big thing is they're reluctant to ask questions because they don't want to sound silly in front of anybody. They really fear pain because they've had pain before and they don't want to experience again, and then their privacy. So I think a good way to address a teen kind of from the start is just say, I know you're really worried about this. I want to help you so that your skin can not only feel better, but look better. And I know you may have some questions that you feel silly about asking, but I want you to know that you're in a safe space. And then ask them if they prefer to have their parents in the room, and then let them know you're going to take care of everything you can with the way you do the procedure, so that they don't need to experience a significant amount of discomfort. So anticipatory guidance. Basically, this is a big buzzword in pediatrics. And what is the anticipatory guidance? Basically, it's what to expect. And I think, again, we all like this, but I think it's really important for a child to know what to expect. And I think you should always involve the child in the discussion if they're school age or older. If there's a toddler in the room, it's really no use in explaining this to them because they won't have the developmental skills to understand what you're explaining, and certainly an infant either. But if you do get to that school age, I do think it's important to explain it, and then do it before the procedure. Use age-appropriate descriptions. And again, think about your words. Don't say it's going to feel like a stick or a prick or a burn or a shot or a bee sting. Nobody likes a bee sting. Say that it's going to be more like a pinch. And then tell them, and I'd love for you to give me an explanation of what you think it feels like so it can help my patients in the future too, so that I can share with them how you felt it, how you would describe it. And then the biggest thing you want to avoid is lying. Not only because it's one of the 10 commandments, but it's one of the 10 commandments, I think, in dealing with pediatric patients too, because they're smart. They have an understanding of what's happening, and they may not be able to have the words to vocalize it, but they do have an understanding. So don't lie, because if you tell them this isn't going to hurt, then as soon as it hurts, they're like, oh, this person lied to me. And then everything else that you said, they're not going to believe anymore either. And they'll start to no longer trust you with the rest of the procedure. So tell them that it is going to feel like a pinch and what to expect. And I think it's just important to review all the steps. And let's go over some positive commands versus negative phrasing. And you really do want to avoid these false choices, which we're going to go over here. So negative phrasing, again, and I don't know if you're like me, but if somebody tells you, no, don't do something, what do you want to do? You want to do it. At least that's me. So if it says, don't open this door, I want to just go, shove that door open. But a kid is going to feel the same way. And again, I think most people feel the same way. If you tell them not to do something, you might want to do it. So instead, tell them what you expect. Build that expectation in your verbiage that you talk to the patient with. So tell them to hold still. That's what you want from them. And again, that is the one thing that I tell my patients. I'm like, when we do this procedure, I don't think that you're going to have the need to yell or scream or any of those things. But I tell them that they can do any of those things, and they can sing, and they can yodel, they can do whatever. But the one thing that they cannot do is move. So, I set that clear expectation up front, and I just let them know why. If you move, then it's going to be dangerous for you, and it's going to be dangerous for me, and it's going to be dangerous for everybody in the room. And we know we have to do this today. So if you can lay still, it's going to go quicker and easier. So again, set that expectation. Don't touch. Basically tell them where to keep their hands. Depending on where you're doing the procedure, keep your hands on the top of your head, keep your hands on your shoulders, keep your hands on your knees. And then you can't stand up. It's better to say, sit on your bottom. Again, being very clear about the expectations that you have for them. And then these are things to avoid, false choice phrasing. So basically, are you ready to go? What if they say no? So basically say, it's time to go. Again, what you expect from them. Can the nurse listen to your heart? Nope. The nurse needs to listen to your heart now. And then really the kiss of death is the okay at the end of any statement. So if you say, do you want to do this biopsy now? Is that okay? And they say no, well, you're still going to move forward with it. So again, just leave off the okay. So what you as the provider, the medical professional in the room needs to bring, and I'm sure that you guys probably heard as interns that, before you go running into a code, basically you run to the code, and then you, from one door away, you stop, take a deep breath, and you walk slowly into the room because you bring your presence into the room. And people are going to be looking to you as the person that sets the tone and sets the mood. So be patient. I can't express this enough. Do not be rushed. You just need to know that you're going to spend the time you need to spend with this patient, and don't feel rushed about it. And then again, allow the child to view you as a friend who's there to help them so their skin feels and looks better. So again, the word I like to use is be professionally playful. So basically you and you can even say, I know I'm a doctor. I know this is, scary what we're doing, but I'm here as your friend today to try and help get to the bottom of what's going on with your skin so that you can feel and look better. And again, just letting them know why you're doing it. Communication, kids, just like anyone, don't have ESP, and they're usually imagining something far worse. So it's better to share the facts with them and let them know what to truly expect. And then that builds trust in that relationship. And then again, the most important thing, I think, in a lot of ways is just a calm demeanor and confidence. You may be shaken inside, but don't let that show. Again, don't let them see you sweat, because the child and the parent, they're usually going to sense your mood and behavior, and then they'll mirror it as well. So if you're calm, it's more than likely they're going to be calm. So common sense tips to lessen those tears and fears from tots to teens. So let's jump right into there after that background. So tip number 1, I think if you have the opportunity, again, most kids don't need to have a biopsy the same exact day. And that gives them time to do a therapeutic trial a lot of times, and come back and be reevaluated, and then let them know that if they're not better, you're going to be setting aside the time for them to get a little pinch of skin to look at underneath the microscope. And I think it's also really important to schedule procedures with sufficient time. It takes a lot longer in a child to do a biopsy than in an adult. So definitely factor in that patient preparation, and it's always longer than anticipated. Again, you also want to be prepared, have sufficient support staff for assistance that come in with you. And again, you just want to let them know that you're going to be bringing in friends to help with the party, and that they're going to be, again, part of this party. And have them just come in at the beginning of the procedure, because you don't want to have to call out in the middle to have available hands come in and assist. So tip 2, I think it's really important that if you're going to do a biopsy, do it in a separate room from the visit. And I know in adults, it's really easy just to kind of get the biopsy right where they're at. But I think this allows the patient to listen and be focused on you before they move into the room with where the procedure is going to happen, because then their anxiety increases and they can't listen. So basically, I think it's important to make sure that, you can give a prescription, or they can get over the counter LMX that they can apply beforehand. If you know that you're going to biopsy a lesion, and they can room the patient, make sure that they have that on. If not, they can apply it for you in case, you're with another patient. Certainly, if you have child life in your institution, and they're available to come if you think you have a really anxious child, that would be helpful. And then just, again, review that procedure, explain it on a child's level, what to expect, get the consent with the parent. And again, everything is written out on the form, and you can say, these are some of the things that, could happen, very unlikely, and then just kind of point to them and say, do you have any questions about these? And again, you don't have to say bleeding, pain, discomfort, all of those things, hematoma, because these kids are like, oh my gosh, I don't know what a hematoma is, but I sure the heck don't want one. And then again, save time to answer questions. And then the next thing you want to do for tip 3 is go and get everything set up in that room. So have your staff have the room ready for you before the patient enters, have the appropriate instruments and supplies already readily available so that you can limit movement around the room. A lot of movement does increase anxiety. So again, limiting that movement, have everything ready and set to go. Have all your instruments laid out and loaded on the tray, and that'll increase your efficiency and also decrease your procedure time. So that is tip 3. Tip 4, again, do not set up the surgical tray or draw up local anesthetic in front of the patient. This is a huge no-no in my opinion. So when they see you putting all these things on the tray, and I think this is also wise, honestly, for all patients, but when they see you laying out the scalpel and the scissors and all of the needle, they see the needle and you're drawing it up from the vial and squirting it out. They're just watching you, and their eyes are getting bigger and bigger and bigger, and their anxiety level is rising and rising and rising. And again, all of this seems very normal for you, but this is not part of a normal day for a child. And then I always like to have the Mayo stand. I like to use just if it's, just a clean procedure, just having kind of a small drape over the top of it, to reduce anxiety. And basically then you want to get the patient settled before you ever move on to using any of those things. And again, at all possible, I avoid the child seeing the needle or the syringe. That's where the real anxiety it comes from. And most of the time, if you've done your LMX well and you use the tips to decrease injection site pain, then they're really not going to know. Sometimes, kids will ask, did you do the shot? Did you do the shot? And I'm like, I don't know, you tell me. And then they've already been injected and they don't even know. So another big thing, and again, injecting, so let's go back to injecting. So as far as injecting a child, again, I always use the LMX before the procedure. And again, you do have to remember that the topical LMX or topical lidocaine is going to be absorbed to a small degree. So you don't want to put it on a big body surface area, because we do know that kids can get absorption because of their increased body surface level. Again, babies more so, toddlers next, and then as they get bigger. But the occlusion does increase absorption as well. And I was involved in a clinic where a child had LMX for molluscum curetting and put on basically a lot of topical lidocaine. And they actually had a seizure in the waiting room with a toxic level of lidocaine. So again, you want to think about that. Remember your dosing for lidocaine. I know you guys all know that, like the back of your hand. Now, the other thing that you can do is, instead of, and I know you guys know this, but when you've used your LMX, I like to put my initial wheel by going straight in, because when we go laterally, we go through a whole lot more nerve fibers, where if you go perpendicular to the skin and raise your wheel, then you can go through that wheel to inject if you need a bigger area. And then they don't feel that. But again, this encounters so many less nerve fibers. So I like to inject like that, raise my wheel, and then go through that. And then you guys all know that buffered lidocaine is less uncomfortable. You guys know that when it's room temperature, it's less uncomfortable. And then there's lots of ways to distract the skin with just vibrating the skin. And then a lot of times when the kids are older, I'll explain the gating theory of nerves, that if I'm, the same nerve fibers that sense vibration can sense pain, and, the gate that's most open. So, shaking their skin. And then they do have these, there's all kinds of vibratory tools, cold spray, all of those things distract the nerves. And I try to incorporate those. And a lot of times, given the kiddo, they call them buzzies, and you can get them on Amazon, but those can have a cold pack on them, and that can be held close by, and it keeps their hands busy so that they are not reaching for the area where you're doing the procedure. So that's just some tips about not letting them see the needle, and then how to do it with less tears and fears. So again, tip 5, think before you speak. Carefully watch the words you use. These kiddos are not asleep, and they are listening and hearing everything you say. So always avoid the word bleeding or blood. I like to say, oh, there's a little bit of heme. Could you hand me a 4x4? And again, you don't want to say knife, because they're like, you're cutting my skin. Oh my gosh. And again, cut. Don't say, okay, now I'm going to cut your skin. And I've heard people say that, believe it or not. So again, just really watch the words that you use when you're with a pediatric patient. And then tip 6, I do think it's really important for most kids to have their parents close by, except when you get to the adolescents and teens who may prefer to have their parents step out of the room. And again, you give them the option of that. But any child that's usually school age or younger will do better when the parent's in the room. The rare exception, if I do have a family where the parent is really anxious, that definitely feeds into the energy of the room. And sometimes I just ask, and just say, I know this is really hard for you, Mom. So I promise we're going to take really good care of your kiddo. And if you just want to step in the waiting room, I promise we'll come get you as soon as we're done. And usually a lot of those kids that have high anxiety parents actually take a breath when their parent leaves. And then just tell them, I know you're brave and I know you can do this without your mom or dad in the room. And I'm going to be here and walk you through it, and we'll get mom back in as soon as you can. The other big thing is you do not want to engage the parent in restraining their child. Now, I'll tell you that sometimes having a child kind of bear hug a parent, if you're going to do something on the back where they can kind of sit up, and mom and dad, if you feel that they can cooperate and actually assist with kind of keeping the arms and legs down with an assistant next to them to help as needed. That's the only time, and that's more just a comfort position is what we call it. So again, you want to not have them restrain their child, just because it's not fair to ask them to do that, because they have to go home with their kiddo, and then the child will no longer trust their parent. So it's important to have enough staff in the room from the start to help you. And then the parent should always be seated at the head of the child. And again, I should underline or highlight the word seated. I had a dad that wanted to stand up, and he's like, no, I'll do better if I just stand up and watch. And of course he got woozy, and then we had 2 patients at the same time, him and the nurse then had to attend to him because he had vasovagal. So anyway, again, have them seated at the head of the bed. And I always have, when I bring them into the room, a chair or a stool already up by the head of the bed on the opposite side of where I'm going to be, kind of like this picture here. So have that kind of prepared in advance. And then again, position the child comfortably on the table. Again, we call it comfort positioning. And if they are more comfortable sitting up, and it doesn't compromise your ability to get the biopsy, and it doesn't increase their chance of moving, then I think that's fine. I think it gives them autonomy and gives them some control in the situation. Just again, that relaxed atmosphere and tone, and you bring that to the room. I think, if you have a planned biopsy where you're bringing them back, tell them, we might be doing a biopsy when you come back next time. Just bring a blanket or something that, you'd like, a special pillow. And then again, giving them some control of the situation, allowing them to participate in decisions, sometimes like the color of suture, or the color of their dressing, their co-band that you're going to put on, I think is just a nice way to give them a bit of control. Tip 8, I think this is really important. And I think this is what makes pediatric biopsies especially challenging sometimes, because you really have 2 patients. Again, you have the parent who's usually wanting to participate in some way, the child. And so the best thing to do is just engage with the child when they're at school age, and that will then make the parent relax because they can see that their child is engaged and feeling comfortable. So that's a good way to diffuse any anxiety for everyone in the room. So just engage with them in conversation. Try to focus on your procedure, of course, but if you can discuss with them what they like to do, if there's a hobby that they have, kind of talk about that. And even if you sound like you're, don't be afraid to be a little bit silly, because that again diffuses the emotion in the room a lot of times. And it also helps them develop coping skills and shows them that they can do hard things when they get through this. And they're very appreciative that you've helped them get through that hard thing. The other thing, if you have a kiddo that's more of an introvert and you're having trouble engaging them, you can ask them beforehand if there's anything that they want to do and have these things available, or they can bring them alone. Nowadays, phones, there's games, videos, music, but a lot of times if kids are a little bit younger, I ask them a song that they want to sing, and then, we'll sing along. The staff and me will sing along. Books, I think the I Spy books are really great. And it kind of acts like a shield. If you have a big I Spy book and mom's up there or dad's holding it, and that actually puts a shield so that they can't see what you're doing. Blowing bubbles, anything like that can be distracting. And blowing bubbles is a way for younger children to actually take deep breaths. Because if you tell a younger child to take deep breaths, they don't know what that means. But to blow a bubble, they have to, and we know that releases chemicals in your brain to calm you down. So tip 9, this is a big thing. So again, try to hide that needle. I usually have the needle in my pocket, my side pocket or top pocket. And then when I have the child positioned on the table, I either use the drapes or I'll use my body to kind of obstruct where you're going to be doing the biopsy. And then again, you also want to position the tray, materials, and specimen out of the eyes line of sight with the child. And then the other big thing is hide any blood tinged material on the tray. So as I'm getting done with the procedure, before I, get them up and kind of wrap up and put the bandage on, I kind of cover up everything that's on the tray. Once, of course, I get my specimen in the bottle, because you don't want to have done a biopsy on anyone and lose the specimen, but you especially do not want to do a biopsy on a child and lose the specimen. And they're small and they can get lost on the gauze or the sheet. So again, just make sure that that specimen's in the bottle before you do cover everything up. And then once you get done, or while you're doing it, of course, this just makes sense. Do it as quickly as possible without sacrificing good technique. This limits the anxiety and restlessness of the child. And also, we know that the anxiety and the restlessness will increase and their attention span will decrease. You won't be able to engage them so much in the conversation anymore if you're taking too long. And then this is really important. For kiddos to choose a suture based on the site, I really like interrupted or skin glue on the face. If I'm thinking about doing, a fine suture, I a lot of times will use skin glue. I think for the scalp, a running cuticular is great. And extremities where they're going to be bending, I think a running subcuticular, and you can do Proline, actually clear Proline, and you don't need to remove that because it's fairly inert, and you can bury your knots if you can leave that subcuticular in place. And I learned this from my mentor, Dr. Annette Wagner up at Northwestern, because that helps prevent scar spread in active kiddos. And then with kids, you do want to use many more deep dermal sutures to maintain the strength of the wound. And again, you don't ever want your epidermal sutures to be what holds the wound together. You want those deep dermal sutures to do the work. And again, with a small biopsy, it doesn't matter. But if you are doing a bigger biopsy, you want to put as many deeps in there as you can. And then limit epidermal sutures, because kids' skin is much more reactive than older people's skin. And then again, for any procedure, even if it's just a skin biopsy, I apply steri strips, and I do even put a bulky dressing on them. If you are doing a procedure over joints, I do sometimes use like a splint to keep their limb from moving and limiting manipulation. And then again, if you're doing more of a big procedure, if it's just a skin biopsy, you're not going to really need any of this. But if you are doing a surgery where you're bringing them in, you want to make sure they keep it covered and restrict their activity for 30 days, and with the strict UV protection. And then suture removal is important. I think these are good times for kids. They do heal fairly quickly and they can become more reactive, and you can have kind of those train tracks left on the skin if you don't take them out, or they can become really embedded and they're hard to get out and more painful. And then at your postoperative visit, of course, the suture removal, sometimes you'll be doing this yourself. Sometimes it can be up to the nurses. But if the suture is stuck on, I always moisten it with gauze first. And if it's crusted, if it was on the scalp, I put a little dilute hydrogen peroxide on a gauze and let it sit on the scalp. And then again, if it doesn't look like it's fully healed for whatever reason, and even if it does look healed, I usually reapply steri strips. Kids are much more active than adults. Again, if it was an excision, I again reiterate the 30-day postoperative restrictions, and then go over your wound care and sun protection. And then I always kind of follow up in 3 months if I've done an excision. And of course, if you've done a biopsy and you're treating something, you're probably going to see them back appropriate to what their diagnosis is. So now that you're all pros with all these tips in your back pocket for pediatric skin biopsies and procedures, any questions or suggestions? Anything that was in the chat, Dr. Davis?
Nope, we didn't have anything in the chat, so I think that was just an outstanding presentation. Surely appreciate it. It's great. I mean, these are the things that obviously you don't think about too terribly often, because we don't do these biopsies very often. So that was wonderful. And, now that we have some time here, I thought you might want to tell us a little bit more about what you have in store for the pediatric dermatology collaboration.
Yes, I would love that, Dr. Davis. Thank you. So I am very excited to announce that we are going to be launching, and again, based on the great platform that Dr. Davis and the staff has built for your dermatopathology education and your career development already, we're going to be adding a pediatric dermatology component to the teaching platform, and it's going to be called Tots to Teens Tidbits. I tend to like alliteration, so Tots to Teens Tidbits, and we're going to be doing that probably on Thursdays. Again, another T thrown in there. But we will see that is probably going to launch in the next academic year of 2023-2024, which is just around the corner. So we're putting all of the logistics in place for that. But we are going to be doing similar teaching as to what Dr. Davis and the colleagues that he has included in the teaching over time, but we're going to be doing CPC cases, tying that into dermatopathology as we can, and then also just practical care of kiddos, not just to help with the boards and your board preparation, but to help you in real life when you get out there, because most people are going to see kiddos in their practice and are going to have to biopsy kiddos and are going to have to interact with their brilliant dermatopathologist and getting the diagnosis right so that you can treat the patients right, so that you have happy tots, teens, and also parents, which is a key component of it.
That will be great. Well, and we're also working on getting Dr. Bree her own pediatrics at sagesdx.com email address, so you can address those issues to her. If you have questions in the interim, certainly feel free to send them to education@sagesdx.com. And for all of the people who are already registered for our Sagis Dermpath happy hours, the announcements regarding the specifics for the rollout of the pediatric educational curriculum will be sent out to you. And be sure to pass them on and share them with your colleagues. So be on the lookout for those announcements. So
yeah, and definitely like the Sagis social medias, and same thing, go out there and Made a Masterpiece on all the social media platforms, because we'll be sharing those announcements too, to help facilitate registration in these courses, because we want to help kiddos love the skin they're in, so that they know that they were made a masterpiece.
that's great. Well, thanks so much, Dr. Bree, and hope everybody has a good evening. Take care.
Thanks, Dr. Bye-bye.
Bye.